Chapter 14: Immune-related adverse events and side effects of cancer immunotherapy.
Even though one major goal in cancer treatment is to get away from the terrible side effects of chemotherapy and radiation, immunotherapy is not perfect. I think in general, the side effects of immunotherapy are probably better tolerated and have a higher patient satisfaction as compared to chemotherapy. In addition, the overall success rate, which seems to be rapidly increasing with new drug developments, makes some of the side effects of immunotherapy more palatable. Even so, there are a few important issues concerning side effects associated with immunotherapy. 1. Doctors may not be quick to recognize some of the symptoms, especially since most will occur while the patient is home, so it is important for the patient to be aware so that they can alert their doctor. 2. Most of the serious side effects of today's typical immunotherapy are autoimmune related and usually respond to steroids. 3. New drugs and combinations may result in side effects that are more severe, even fatal, and may have a different mechanism than autoimmune issues, which means they may require different treatments than steroids. Autoimmune side effects. We have discussed that with the common immunotherapy drugs used today, mostly anti-PD-1, PD-L1, or anti-CTLA-4 block receptors that prevent your immune system from attacking your own body, it is certainly understood that this can increase autoimmune conditions. In general, you could expect to see any type of autoimmune conditions that may occur in normal disease processes, such as rheumatoid arthritis, Hashimoto's thyroiditis, and colitis. However, with cancer immunotherapy, it is possible to see autoimmune issues almost anywhere in the body, and certainly some that would be very strange or extremely rare to occur naturally. There is a long list of possible autoimmune conditions, but certainly ones to consider are pneumonitis, lungs, hepatitis, liver, thyroiditis, thyroid, colitis, colon, diabetes, pancreas, hypothysitis, pituitary gland, rash, skin. Though I will not go into the detailed treatment of these issues, in many cases, corticosteroid treatment may be necessary. We usually warn our patients that any changes in breathing or shortness of breath could be from pneumonitis, an autoimmune inflammation in the lung. This needs to be evaluated immediately, and my suggestion is with a CT scan of the chest. I would like to mention here that a chest X-ray alone is not very sensitive for picking up this condition. Though it may be the first step, ultimately a CT scan probably will be needed. It is important to note that the appearance of autoimmune pneumonitis can resemble pneumonia in some cases, but the treatment is clearly different. Every effort needs to be made to distinguish these apart from each other. In general, pneumonia, lung infection, will have an elevated white blood count and fever, whereas pneumonitis typically would not. Sometimes the distinction is not so clear. In regards to thyroid issues, most commonly the autoimmune issue results in a low thyroid hormone, hypothyroid. In some cases, this may start as a high or hyperthyroid condition because the gland is being destroyed by the immune system, which causes a rapid sudden release of the thyroid hormone, later followed by a decrease in thyroid hormone production. The increase in thyroid hormone may cause symptoms such as anxiety and a rapid heart rate, which may need to be treated with medicines to control these symptoms, such as a beta blocker. In other cases, the autoimmune antibodies can actually stimulate the thyroid, causing an increased production of thyroid hormone, also known as Graves' disease. This is where the increased thyroid hormone production can persist, unlike the first condition I described of thyroiditis, where hormone levels may first come up, but later become low. In either case, it may be necessary to have an endocrinologist evaluate and treat these situations. In regards to autoimmune hepatitis, it is important to periodically monitor liver enzymes. Mild increases can just be monitored, but more significant increases will need to be treated with steroids or, in rare cases, other immune-suppressing drugs. There are many different recommendations on how to treat these related autoimmune conditions. I would refer someone to either the prescribing information provided by the drug manufacturer or to consult with their doctor. There are also helpful treatment guidelines on the website www.uptodate.com, which is an evidence-based medicine website used by many physicians. The book SITC's Guide to Managing Immunotherapy Toxicity by Ernstoff et al., published in 2019, is an excellent reference book and a must for the library of any doctor involved in the use of cancer immunotherapy. Typical side effects or autoimmune-related events with immune checkpoint therapy. The following reactions are among the most common side effects or autoimmune-related events experienced by patients who undergo immune checkpoint therapy: fatigue, skin rash, itching, vitiligo, dry mouth, diarrhea, colitis, liver toxicity, hepatitis, pneumonitis, inflammation of the lung, thyroiditis, inflammation of the thyroid, hypophysitis, inflammation of the pituitary, adrenal insufficiency, diabetes. In addition to these reactions, some of the most rare side effects below may become more common in the future with new drugs or combinations. These may include neurological issues and cardiac toxicity. These thankfully seem rare, but when they do occur, they can be very severe. We often do a cardiac evaluation on patients prior to treatment, with monitoring of cardiac enzymes via periodic lab tests after they start treatment. Again, these are some of the more common issues, but not a complete list. If you are being treated with immunotherapy, do not hesitate to discuss any concerns with your doctor. Skin rash, itching. Skin rashes and itching may not seem like a major problem, but it can be extremely distressing and annoying for patients. Commonly, if this is in a small localized area, steroid creams can be fairly effective. Using antihistamines can also be helpful. However, the associated itching, especially over a larger area of the body, can really be a problem when it does not respond to these conservative treatments. I want to share something that we had success with, most typically in patients on systemic PD-1, PD-L1 inhibitors. A publication by Ito et al. In Lung Cancer, July 2017, titled "Aprepitant for Refractory Nivolumab-Induced Pruritus" described how aprepitant, AMEND, an oral neurokinin 1 receptor antagonist, was useful in a case report. We have also used this with fairly good success as well. This medicine is normally used for the prevention of chemotherapy-induced nausea and vomiting. The medication can be fairly expensive if not covered by insurance. Generally, it only needs to be used for 3 to 5 days to have effect. So, if you're having issues with itching that are not responding to other treatments, it may be wise to suggest this to your doctor. I would recommend that you show them the above article, which you can find the summary of on the internet. Tumor lysis syndrome. Though relatively rare, tumor lysis syndrome, TLS, should be considered and monitored for in immunotherapy cases, especially with new immunotherapy combinations in a patient with a heavy tumor burden. TLS can occur when there is a rapid destruction of cancer. It may seem like a good problem to have, but it can become very serious. The rapid destruction causes a release of materials within the cancer into the blood, which, if severe and not treated properly, can become fatal. The dead tumor causes an increase in electrolytes, potassium and phosphate, with low calcium, increased uric acid, and blood urea nitrogen, BUN. These breakdown products can ultimately lead to kidney failure. Due to these electrolyte issues, this can be monitored by lab analysis. The treatment of tumor lysis syndrome is well described, and one of the most important aspects is IV hydration. I will add that oncologists are often very surprised that this can occur with immunotherapy. I have seen it in patients and had oncologists delay treatment because they did not feel it was possible. My suggestion is to make sure to get follow-ups labs, and if the lab suggests tumor lysis, it is best to treat it as such as soon as possible. Cytokine release syndrome. Cytokine release syndrome, CRS, is one of the most problematic issues in cancer immunotherapy. Originally extremely rare, the incidence of CRS is rapidly increasing, especially with the development of new agents in combination immunotherapy. CRS has given great problems to patients treated with CAR-T, which has been successful in blood-borne cancers, but carried huge risk. We also began seeing it in more patients, with bulky disease when using combination immunotherapy directly injected into the tumor. Basically, it is a condition caused when the immune cells produce a large amount of immune-stimulating substances, called cytokines, in response to mounting an immune attack, in this case, against cancer. It seems the larger amount of cancer burden the patient has, the higher the risk there is for CRS. The immune system is used to attacking things that are relatively small, such as a viral or bacterial infection that does not have much mass, but cancer tumors can be larger than one of your organs. When the body attacks something so massive, it is not without potential consequences. Symptoms of CRS typically include fatigue, fever, loss of appetite, vomiting, low blood pressure, seizures, headache, and confusion. This is very similar to the symptoms associated with severe infection and sepsis. Fatigue, fever, and loss of appetite can be common in immunotherapy as well, but CRS progresses to these other symptoms, often starting with low blood pressure. For me, this was the major drawback of immunotherapy. I feel it is one reason that it is best to treat patients as early as possible before their disease becomes too bulky, since increased tumor burden is a risk factor. Other thoughts are to use chemotherapy, radiation, or ablation to reduce tumor volume first, though often this is not possible. However, thankfully, recently some major breakthroughs have been made. They may not eliminate the problem, but hopefully they will make it manageable in most cases. In a study published in Nature Medicine, May 2018, by Norelli et al., they showed that cells of the immune system called monocytes produce interleukin-1, IL-1, and interleukin-6, IL-6, causing CRS in a specific mouse model. Importantly, the study showed that IL-1 seems to be sourced of associated neurotoxicity in CRS. This type of toxicity is normally the most dangerous and fatal aspect. Besides supportive care, the typical treatments for CRS are steroids, histamine blockers, and potentially the IL-6 blocking agent tocilizumab. However, this last treatment has not been as successful as hoped, especially in a case where neurological symptoms have developed. Norelli et al. Showed that IL-1 seemed to start this whole cascade and was responsible for the neurological toxicity. This led them to show that IL-1 blocking drug anakinra did have success in preventing the neurological-related toxicity. This was in the animal model, but it is important enough that we should consider using this therapy in patients right away. Thankfully, anakinra is already FDA approved for treatment of rheumatoid arthritis, so it can be used off-label in the US. TNF inhibitors. In a study published in Nature, May 2, 2019, Paris, Rees et al. Described how the prophylactic use of TNF blockers increased the effectiveness of the combination of CTLA-4 and PD-1 immunotherapy, while at the same time reducing autoimmune colitis and hepatitis. Keep in mind, this is in a mouse model, but it is still promising. In the study, they used the TNF inhibitor etanercept Enbrel. They showed that not only were adverse autoimmune effects reduced, but also there was increased T-cell infiltration in the tumor that resulted in increased complete tumor rejection. Overall, this sounds like a win-win situation. Though clearly we need further studies, since etanercept is FDA approved, it could easily be adopted as an off-label treatment. Hyperprogression. Hyperprogression is an actual increase in the cancer growth rate caused from the treatment with immune checkpoint inhibitors, PD-1, PD-L1, such as Opdivo and Keytruda. Reports indicate this may occur in 4 to 29% of patients treated in multiple cancer types. It is not as clearly defined and can be confused with pseudoprogression, where patients have an initial increase in tumor size first and ultimately a decrease. The degree of tumor increase with hyperprogression is greater than that seen with pseudoprogression, with often a doubling in tumor size and the development of new tumor locations as compared to the pre-treatment and first post-treatment scans. It is important to note that hyperprogression will shorten the patient's lifespan, meaning it will make them worse than if they were not treated at all. Frankly, that is a little scary. Studies have indicated an association with MDM2 gene amplification and EGFR aberrations. However, these are still not clear. More promising, in a recent study published in Clinical Cancer Research by Lo Russo et al., September 11, 2018, they implicated tumor-associated macrophages, TAMs, as a potentially being a major culprit. Basically, they described that part of the PD-1, PD-L1 antibody, drugs such as Opdivo, Keytruda to block these receptors, binds to a part of the tumor-associated macrophages, TAMs, and may actually activate them to become more tumor-protecting. When this part of the antibody, drug, was removed, the enhanced growth rate of cancer was not seen. In the mouse model, they also found that using clodronate, at first-generation bisphosphonate, used for the treatment of osteoporosis, approved in many countries but not the US, was able to reduce the macrophages and hyperprogression. As I have mentioned, tumor-associated macrophages may be an important area of immunotherapy resistance. This will be an area that needs to be addressed with combination therapy. Several drugs are in development for this, with one of the most promising being CSF1R inhibitor. Also, an anti-Marco antibody was able to convert the tumor-protecting macrophages into the tumor-attacking type. As you learned earlier in Chapter 13, 6-gingerol is a natural substance that can inhibit TAMs, though probably not to the level of these experimental drugs, but at least it is easily available. Clodronate may be an option as well, at least in countries where it is approved. Studies have shown that zoledronic acid, Zometa, has similar effects and is approved in the US. The extract from milk thistle, Silibin, may also have a role in inhibiting cancer-protecting tumor-associated macrophages, TAMs. Also, don't forget mangostin, a human STING agonist mentioned earlier, because it not only activates STING, but also converts TAMs from the M2 to M1 type, tumor-protecting to tumor-attacking. However, keep in mind that this would need to be injected into a tumor directly. In summary, even though the goal of immunotherapy is to have a successful cancer treatment with less side effects of traditional chemotherapy and radiation, there remain many potential serious side effects that can be caused by immunotherapies as well. These must be monitored and, in certain cases, may require treatment. It is important for the patient to be aware of these potential issues and notify their doctor immediately if concerning symptoms develop.